Hi, everybody, and welcome to 19 to 0's webinar series on COVID vaccines. This webinar today will be about new vaccines, some that have been authorized and some that are not yet authorized, but soon to be put forward by Health Canada. The primary objective of this slideshow is to provide you with accurate information so you can confidently roll up your sleeve when the time comes and advocate about this vaccine to your patients and colleagues. This slideshow was developed by a multidisciplinary team of nurses, physicians, pharmacists, and public health experts, and is up to date as of February 24th, 2021. At the time of this recording, more than 21,000 Canadians and nearly 500,000 Americans have died of COVID-19 in the past year, and many people struggle to return to normal life even after the COVID infection. So with all this, there's very good reason to be vaccinated for your own health. You simply cannot know how you personally will be effective. Our aim is for healthcare workers to get educated about the vaccines, get vaccinated, and get skilled in communicating about vaccines with your patients and colleagues. The first vaccine we'll talk about today is Astra Zeneca or Oxford vaccine. And this one was just recently approved by Health Canada on February 26th of this year. This vaccine is an adenoviral vector vaccine. The adenovirus acts as a sort of Trojan horse, carrying a small piece of DNA that codes for the spike protein of the SARS coronavirus into the cells in our own body. Once in the cell, it inserts the DNA chunk into the nucleus where it's translated into RNA, which tells the cell to manufacture pieces of spike protein that will then be presented on the outside of the cell. The spike protein is then identified by the immune mechanism in our body to trigger an immune response. This modified adenovirus will not make you sick. Adenovirus vaccines have been developed for several other diseases, including for Ebola and Zika, so this is not a new technology just being used for coronavirus. The vaccine is 2 doses, given 28 days apart, and the trial included almost 24,000 participants and reported an overall efficacy of 62%. However, a small subset of participants were dosed with a lower first dose and then a higher second dose and had an efficacy of 90%. The increased efficacy is postulated to have occurred because of longer time frame between the first and second dose in this subgroup. This vaccine has been approved for use in many other parts of the world, such as the UK and EU, as well as now being approved for use in Canada. In spite of the lower overall efficacy compared to the mRNA vaccines that we have currently approved, there are many advantages to the Oxford AstraZeneca vaccine. Number one, it is more stable and doesn't need to stay frozen. Refrigeration at normal fridge temperatures is adequate for vaccine stability. This allows the vaccine to be more readily deployed to more remote areas and can be stored and distributed at pharmacies or clinics rather than just centralized locations. The overall efficacy rate of 62% refers to preventing any symptomatic disease and would be on par with influenza vaccines in a good season. However, the vaccine is very effective at preventing severe disease, hospitalization, and death, which of course are the greatest concerns from COVID-19. The dosing interval is much more flexible as well than the mRNA vaccines, with indication that it may be more effective with longer dosing interval, allowing more people to be vaccinated with an initial dose and spacing out the second dose. The Johnson & Johnson vaccine is another adenoviral vector vaccine. The main difference here from AstraZeneca is that this is only a single dose vaccine, so a second booster dose is not required. The global phase 3 ensemble trial had 43,783 participants, which is very large in terms of vaccine trials. 28 days after vaccination, it was found to be 72% effective in the US and 66% effective overall at preventing moderate to severe COVID-19. In the South African arm, it was 57% effective, indicating a reduction, but still efficacious against the dominant South African variant in the region. It was 85% effective at preventing severe disease and death overall. There were no allergic reactions noticed, and fever was only presented in 9% as a side effect, which is significantly less than the mRNA vaccines. In this study, serious side effects were actually more commonly reported in the placebo group than the vaccine group itself. The Novavax vaccine is another different type of vaccine, which is a protein subunit. It uses lab-grown nanoparticles of spike protein from the SARS coronavirus to initiate an immune response. The vaccine does use an adjuvant called saponin, commonly found in plants to help the body build an immune response. The vaccine type is common to vaccines in the existing childhood immunization schedule, including things like hepatitis B, HPV, and influenza vaccines. The Novavax vaccine is a 2-dose vaccine administered 21 days apart, and like the adenovirus vaccines, it requires only refrigeration at normal fridge temperatures, making it much easier to transport and store. The stage 3 trials of Novavax demonstrated an 86% efficacy against the UK variant and 95% efficacy against non-variant cases in the United Kingdom. As well, it demonstrated a 60% efficacy against the South African variant. This vaccine candidate is the only one currently that Canada will have the capacity to produce locally and domestically. The company has plans to further develop the vaccine specifically targeted towards the South African variant. As with any RNA virus, the COVID virus is susceptible to mutations, and some variants have emerged that seem to increase transmissibility of the virus and allow it to evade the antibody response. This is to be expected, but does pose concern for long-term efficacy of vaccines and creates the possibility of future waves of the pandemic to occur before most of the population is vaccinated. The most common variants presently circulating are those originally identified in the United Kingdom, South Africa, and Brazil. The UK variant seems to bind more tightly to the ACE2 receptors in the body that allow the SARS-2 coronavirus to invade cells and create infection. The South African and Brazil variants are similar and include multiple mutations on the spike protein that seem to evade antibody response, causing a reduction in overall vaccine efficacy and a higher rate of reinfection. As genomic sequencing becomes more widespread, it's expected that we will uncover more variants. For instance, there are emerging variants servicing the United States and Nigeria for which we still know very little about. The increased transmissibility of these variants leaves the opportunity for explosive growth when protective public health measures are relaxed, such as was seen in the outbreak in Newfoundland and Labrador, which had previously avoided significant case numbers of COVID-19. Thanks everybody for tuning into our COVID-19 vaccine webinar. We hope it helps you feel confident about getting your vaccine so we can move together towards a brighter future. Thank you.